heart failure can be found on page 737, and we're just going to quickly go over this. Heart failure is a complex clinical syndrome that results in the inability of the heart to provide sufficient blood to meet the oxygenation needs of tissue and organs. What happens is there is a defect in either the ventricular filling, which is the diastolic function, or ventricular ejection, which is systolic. So remember, the ventricular filling is going to be a diastolic function, and ventricular ejection is the systolic. And these are the key manifestations of heart failure. The amount of blood pumped by the left ventricle with each heartbeat is called the ejection fraction. The ACCF, or the American Academy of Cardiology Foundation, has adopted the term heart failure with reduced EF, and you'll see it abbreviated as capital HF, small r, EF, and heart failure with preserved ejection fraction, and you'll see that as HF, capital HF, little p, EF. Don't worry about that part for the test. It's just one of those things that if you see it and you're reading this is what they're talking about, to describe systolic or diastolic heart failure. Heart failure is associated with numerous types of cardiovascular disease, which, remember, we talked about CVDs, particularly long-standing hypertension, coronary artery disease, myocardial infarction. In contrast to other CVDs, heart failure is increasing in incidence and prevalence. This is due in part to better survival after cardiac events and the aging of population. So as healthcare gets better at treating and saving people from like a massive MI where 10, 15 years ago they would have died, we're starting now to see an increase in heart function, people with heart failure, because remember, with an MI, you have that damage to the heart muscle. So, or with CAD, you have that damage to that area. So this is why we're starting to see a rise in the number of people with heart failure, and people are living longer. The American Heart Association estimates that over 650,000 new cases are diagnosed each year. Heart failure is the most common reason for hospital admissions in adults over the age of 65. So, as you're doing your clinicals and stuff now, if you see somebody in the hospital, see if they happen to have something like some sort of heart failure, like congestive heart failure or left or right-sided heart failure, in their diagnoses. It's just kind of one of those interesting things that you might want to look at. The complex progressive nature of heart failure often results in poor outcomes, the most costly being hospital readmissions. So these are the ones that you're going to see admitted time and time again. They're the ones that, will be in the hospital for a week to 2 weeks, and then they're out for a couple of months, maybe 3, and then they're back in. So because of the severity sometimes of the damage to their heart. So you will see them in the hospital quite frequently. Approximately 25% of patients discharged with the primary diagnosis of heart failure are readmitted within 30 days. The total cost of heart failure care in the United States exceeds $40 billion annually, with over half of these costs spent on hospitalization. So, we live longer, we're able to save people after having a coronary event, a heart attack or whatever, and now then we're starting to see the aftercare of it. Risk factors of heart failure are hypertension, coronary arteries disease, or comorbidities which contribute to it. Like they've had hypertension and coronary atherosclerotic disease. They've got more than just one medical diagnosis leading to it. They have modifiable risk factors, obesity, smoking, stuff like that, which we've already talked about, and properly treated and managed incidence of heart failure can be reduced by 50%. So, as we have talked about before in previous discussions, when you are dealing with, especially with cardiology, there are things that you can change, things you can't. So we really, a lot of times, focus on the modifiable with it. So to reduce the incidence of somebody with heart failure, you go after the modifiable. This is why preventative, this is why you start looking at people earlier that are starting to say, hey, they've got hypertension, look at them. Look at the family history. Look at, their other modifiable risks, so you can help reduce their risk and maybe prevent an MI, so they don't end up with heart failure later on in life. So, etiology of heart failure found on page 737. Anything is basically anything that interferes with mechanisms that regulate cardiac output. Your primary cause is going to be conditions that directly damage the heart. So anything that is damaging the heart, like an MI, hypertension, pulmonary hypertension, hyperthyroidism, things that are going to cause damage to the heart or make the heart work a little bit harder, are going to cause this. Precipitating causes are conditions that increase workload of the ventricles. So when you're looking at precipitating factors, you're looking at an infection, thyrotoxicosis, hypothyroidism, bacterial endocarditis, which is an infection that increases the workload of the heart on that, obstructive sleep apnea. This is why it's always very important when you're doing your health history. You need to ask the patient, have you been told that you snore when you sleep? Have you been told you needed to have a sleep study done? Because if you're not sleeping, if you're having sleep apnea, you're snoring, your body is not expelling enough carbon dioxide, your heart is working harder. A lot of times you will see this in obesity, with obese people. So, it kind of plays a role into this, because a lot of times you may have obesity, and you may have hypertension, and you may have sleep apnea. So this is some of the things that you'll see with people that have been diagnosed with heart failure, is they have all three of these things going against them, basically, on that. The most common form of heart failure is left-sided heart failure. Left-sided heart failure results either from the inability of the left ventricle to empty adequately during systole or fill adequately during diastole. Left-sided heart failure can be either classified as systolic, diastolic, or mixed systolic or diastolic heart failure. Okay, left-sided heart failure. Go back to how the blood flows. This is why I taught our very first day of lecture. I said you guys need to go back. You need to watch the video I posted. You need to go back to your AMP book. You need to look in your textbook, and you need to be confident in how the blood flows into the heart and out of the heart, where it goes to the lungs, where it goes to the rest of the body, because now we're into left-sided heart failure. Left-sided heart failure results from left ventricular dysfunction. This prevents normal forward blood flow and causes blood to back up into the left atrium and pulmonary veins. Remember, pulmonary is lungs. The increased pulmonary pressure causes fluid leakage from the pulmonary capillary bed into the interstitium and then the alveoli. This manifests as pulmonary congestion and edema. So with left-sided heart failure, you're going to have what? You're going to have pulmonary edema. It's pulmonary, remember, it's lungs. So just think of when you see left-sided heart failure, we're talking about lungs on that. Okay. The pathophysiology of systolic heart failure. Remember, there's two different kinds of this. Systolic heart failure, also known as capital HF, little r, EF. So don't worry about it, but that's in your reading. So if you see that, it's just one of those things. If you see what those abbreviations are, this is what it means. Systolic heart failure results from an inability of the heart to pump blood effectively. The hallmark of systolic failure is a decrease in the ejection fraction. Normal ejection fraction is 55 to 60%. Patients with systolic failure generally have an ejection fraction less than 45%. It can be as low as 5 to 10%. Systolic failure, is caused by impaired contractile function. Example, an MI has happened. Increased afterload, example would be hypertension, cardiomyopathy, and mechanical abnormalities, something, like a valvular heart disease. The left ventricular and systolic failure loses its ability to generate enough pressure to eject blood forward through the aorta. Over time, the left ventricle becomes dilated, hypertrophied, it doesn't want to work, it becomes kind of stiff and ineffective. The weak heart muscle cannot generate adequate stroke volume, or SV, which affects cardiac output. Because the left ventricle cannot effectively push blood forward, and diastolic volumes and pressures in the left ventricle increase. The pressures are going to increase. When the left ventricle fails, blood is going to back up into the left atrium. This is going to cause fluid accumulation in the lungs. The increased pulmonary hydrostatic pressure causes fluid leakage from the pulmonary capillary bed into the interstitium and then the alveoli. This is where you get pulmonary congestion and edema from. This is where you get adventitious lung sounds from. This is where you start seeing congestive heart failure. This is where you hear the term wet lungs a lot at. Now, diastolic heart failure is the inability of the ventricles to relax and fill during diastole. Approximately 50% of patients with heart failure have diastolic failure. Hypertension is the most important cause, or the number one cause, of diastolic failure. Other risk factors include old age, being female, diabetic, and obesity. With diastolic failure, the left ventricle is generally stiff and non-compliant. It means it doesn't listen to the SA node and stuff. It's like, it's just kind of like a teenager sometimes. It just does not do what it needs to do. Diastolic failure is characterized by high filling pressure because of stiff ventricles. Decreased filling of the ventricles result in decreased stroke volume. So we're looking at decreased filling of the ventricles, which are then resulting in decreased stroke volume and cardiac output. The end result of diastolic failure is the same as systolic failure. You're going to have pulmonary congestion. Remember, we're still on the left-sided heart failure. Left-sided heart failure is what? It leads to the lungs. We're talking pulmonary. So always remember, left-sided goes to the lungs. Diastolic heart failure is diagnosed by the following criteria. You need to have signs and symptoms of heart failure, normal ejection fraction, evidence of left ventricular diastolic dysfunction. This is where an echocardiogram is going to be done, or a cardiac catheterization. Remember when we talked that in the lecture about what an echocardiogram is and what a heart cath is, you're measuring the ejection fraction on that. Therapies for diastolic failure are targeted at reducing underlying risk factors and treating comorbidities. Prevention, treating what you can change. Diastolic heart failure is the inability of the ventricles to relax and fill during diastole. Remember that. So just remember that this is a failure for it. Diastolic is the inability of the ventricles to relax and fill during diastole on that, okay? Okay, this is just a little picture that is posted of left-sided heart failure. There's other ones if you want to Google on Pinterest that kind of show you show you differently if you want to do that, but I kind of like this little guy here. It shows you what left-sided heart failure is. Remember, left-sided heart failure is what? Pulmonary. Think about where the blood's flowing, how it gets out of the heart. So you're talking about paroxysmal nocturnal dyspnea, elevated pulmonary capillary wedge pressure. What you need to remember, the biggest thing is what I want you to remember, especially for the test, pulmonary congestion, which with pulmonary congestion, signs and symptoms of it are crackles, cough, wheezes, blood-tinged sputum, tachypnea. You're going to have restlessness, confusion, orthopnea, tachycardia, exertional dyspnea, fatigue, and cyanosis. Remember, left-sided, you're going to see issues with the breathing. On that, it's all going to be lung-related on that. Now we're going to talk just very briefly about mixed heart failure. It's found on page 738. Remember, mixed heart failure is a mix between systolic and diastolic failure. It's still left-sided, but it's a combination of it. This is seen in diseases such as dilated cardiomyopathy, DCM. They have a poor ejection fraction of less than 35%. They'll have high pulmonary pressures. They'll have biventricular pulmonary failure, which means both ventricles may be dilated and have poor filling and emptying capacity. So bi, remember, always means two. So the patients often have extremely low ejection fractures, high pulmonary pressures, and biventricular failures. Remember, biventricular means both ventricles are dilated and have poor filling and emptying capacity. Okay, now we're moving on to right-sided heart failure, found on page 739. Right-sided heart failure occurs when the right ventricle fails to pump effectively. When the right ventricle fails, fluid backs up into the venous system. This causes movement of fluid into the tissues and organs. This is where we're going to see peripheral edema, abdominal ascites, hepatomegaly, jugular venous distension. Now we're on the right side. Now, how does the body get from the blood get out of the heart? What is it doing when it's going to the right side? You're going to the body. On the left side, you're going to the lungs. Now on the right side, you're going to the body. You're going out. You're going to see peripheral edema, which means edema in the extremities. You're going to have abdominal ascites. You're going to have jugular vein distension. So you're on the, it's not, think of right-sided as more external, where you're going to see the stuff externally, where left-sided is more, it's respiratory on that. The most common cause of right-sided heart failure is left-sided heart failure. So typically if you see somebody with left-sided heart failure, you're going to also start seeing right-sided heart failure. As the left ventricle fails, fluid backs up into the pulmonary system, causing pressure in the lungs, increased pressure in the lungs. The right ventricle has to work harder to push the blood back into the pulmonary system. Over time, this increased workload weakens the right ventricle and gradually it fills. Other causes of right-sided heart failure is independent of the function of the left ventricle, include right ventricle infarction, pulmonary embolism, and what we call cor pulmonale, which is right ventricular dilation and hypertrophy caused by pulmonary disease. So the big thing, the takeaway from this I want you to understand is with right-sided heart failure, you usually see it after the heart has been working really, really hard and dealing with left-sided heart failure on that. Okay, continuing on. The patient with ventricular failure of any type may have low blood pressure, low cardiac output, and poor renal perfusion. Heart failure can have abrupt onset as well as with acute MI, or it can be a slow process resulting from slow progressive changes. The overloaded heart compensates to try and maintain adequate cardiac output. So we talked a little bit about this with, like people with blood pressure sometimes. They don't know that they have a problem with high blood pressure. You don't know you have a problem with certain things until you go in and see the doctor, because you're very asymptomatic. So sometimes it's because the body has learned to compensate. So you see this a little bit with this. The main compensatory mechanisms include neurohormonal responses, and we're talking about your renin, angiotensin, aldosterone system, and your sympathetic nervous system, ventricular dilation, and ventricular hypertrophy. Okay, this is another picture of right-sided heart failure. This is where you're going to see fatigue, peripheral venous pressure, ascites. Your liver and spleen are going to be enlarged. You're going to, if you look at the picture where she's got a large belly, this is abdominal ascites. You've got peripheral edema going on, which we call it dependent edema, swelling of hands and fingers, anorexia, and complaints of a GI distress. With abdominal ascites, they're going to have anorexia, where they're not going to want to feel like they want to eat. A lot of times they have a lot of GI distress, nausea. They just aren't hungry. But then a lot of times, some of them, you'll see they look like they're about 9 months pregnant, because all that fluid building up in there. And fatigue, they are going to be extremely, extremely tired. It's not because maybe they're obese or whatever. It's because their heart is working so hard to compensate for what's going on with the left-sided heart failure, that now we're starting to see it bleed over into the other side, and now we're starting to see it in, the swelling of the feet, the swelling of the hands, the fatigue, the ascites with that. Okay, as we discussed with how heart failure and stuff works, you need to also understand how the body compensates. So there's what we call a compensatory mechanism in the body that the body uses to help with, maintaining homeostasis in the body. So when we would, as I mentioned in a previous slide, the renin, angiotensin, aldosterone system, the RAS system, which you'll see abbreviated as RAAS, helps the body. It's this regulatory system that works to maintain normal homeostasis in the body. So once this system has been activated, it results in blood pressure control and fluid and electrolyte balance. So if there's something off in the system and in the body, such as the cardiac output has decreased, there's been an issue with it, the body works and kicks in this system, the RAS system, which will then work to compensate for what's going on and help regulate the blood pressure control and help regulate the fluid and electrolyte balance in the body. And this happens in response to stress. So when there's stress, the body senses stress or puts out stress signals in the system. The role of the RAS system is then, the mechanism of the RAS system, is initiated, and its role is to promote retention of fluid and sodium and cause vasoconstriction to raise blood pressure. So sometimes when we're looking at stress, like if you have decreased cardiac output, you have decreased blood pressure and stuff, the body senses it, this is stress, so then it kicks in this RAS system, which then works to say, okay, the blood pressure is low, so this is what I need to do. What we're going to do, body, is we're going to retain fluid and sodium, and we're going to cause some constriction, and we're going to get that blood pressure up there. However, if the body keeps getting this system activated and stuff, as is with heart failure, because of, there was a myocardial infarction and something has happened and stuff to the heart, and it's not working right, then it is responsible for the signs and symptoms, for causing like edema and stuff like that. So once this has been, this is normal, it happens, it's our body's response to kind of level things out, and then once everything is leveled out and everything's fine, the stress is removed, whatever, the body settles down, the system kind of goes dormant and monitors. Once it's activated again, it keeps doing this. So with heart failure, what you see with the system, it keeps getting activated, and then the body does not know how to function unless it is at this higher level, and then the body works harder. So this is where you can see where the body and the heart start working harder to maintain a stable homeostatic environment. Okay, this is a continuation of the previous slide with it. So this is showing you kind of what is the neurochromonal response to the RAS system being activated. As the cardiac output falls, blood flow to the kidneys decrease and is sensed as a decreased volume. The sympathetic nervous system, which you can find an explanation of that in your book on page 739, is activated to increase the blood pressure and the heart rate. This then releases the aldosterone from the adrenal cortex, resulting in sodium and water retention. Okay? Then which then causes peripheral vasoconstriction. Remember, it's causing it to get tight, and it's causing the blood pressure to increase. The pituitary gland at the same time releases the ADH, which results in water reabsorption. So the outcome of the whole they call this the RAS cascade, is the outcome of this cascade results in further water and sodium retention in an already overloaded state. This increases the workload of the failing heart. So this is why it's very important once we see people that are pre-hypertensive, they're starting to show signs towards heart failure, that we need to try to do the modifiable risk factors that we can to help reduce the workload on the heart. This is also why even though we're working on modifiable, sometimes we'll go ahead and we'll put them on medications to help the heart work effectively. Okay, so in heart failure, continuous activation of the neurochromonal response, or your RAS system and your sympathetic nervous system, lead to elevated levels of norepinephrine, angiotensin II, aldosterone, ADH, endothelin, and pro-inflammatory cytokines. Together, these factors result in increase in the heart's workload, ventricular dysfunction, and ventricular remodeling. Remodeling is basically where it involves hypertrophy of the ventricular myocytes. It just kind of is basically just remodeling and the ventricular or whatever it's working on, and in this case with ventricular, and it's not going to work as effective. It's going to be stiffer. It's not going to respond like it needs to with that. This results in large abnormally shaped contractile cells. This altered shape of the ventricles eventually lead to increased ventricular mass, increased wall tension, increased oxygen consumption, and impaired contractility. Although the ventricles become large, they become less effective pumps. So even though they're becoming larger, so they're not pumping effectively, which is very important, as we discussed at the beginning of this lecture on day 1, that the heart is a pump, and it needs to work well in order for everything in the body to function correctly. Because if the heart's not functioning correctly, and you have left-sided heart failure, then you've got fluid building up in the lungs, which this is a continuous cycle. Then you go into right-sided heart failure sometimes, and then this is where you have the ascites and the edema. So like I have said before, if you have a little break in the chain, or you have a weak chain, the system isn't going to work well. So if you have a weak heart, your body is not going to work well. It's not going to heal well. It's just not going to function properly. Ventricle remodeling is a risk factor for life-threatening dysrhythmias and sudden cardiac death. Drug therapies to prevent or reverse remodeling and decrease mortality rate are recommended. These usually include ACE inhibitors, beta-adrenergics blockers or beta blockers, and aldosterone antagonists. And we'll talk more about these medications once we get into pharmacology. We'll go in a little bit more detail about them so you can understand what their classifications are and what their main functions are, and that'll really help with that, because there's certain medications that they are going to give to treat this. So, but like I said, we will, really get into this when we get into the pharmacology on that. Okay, so continuing on with compensatory mechanisms, we're going to talk about dilation. Dilation is the enlargement of chambers of the heart. This occurs when pressure in the heart chambers, usually the left ventricle, are elevated over a period of time. The muscle fibers of the heart are going to stretch in response to the volume of blood in the heart at the end of diastole. The degree of stretch is directly related to the force of the contraction of systole. The increased contraction initially leads to increased cardiac output and maintenance of blood pressure and perfusion. Dilation starts as an adaptive mechanism to cope with the increasing blood volume. So you see this dilation happening as the heart learns to try to compensate for the increased volume for a weak heart. Eventually, this mechanism becomes inadequate because the elastic elements of the muscle fibers are overstretched and can no longer contract effectively, thereby decreasing cardiac output. It's like when we talked about you have a piece of elastic and you keep pulling it and holding it and having it stretched out, or a rubber band, you keep it stretched out to the maximum part. You keep doing that over a period of time, it becomes kind of loosey-goosey, and it does not pull back like it used to. You know, the first time you get a piece of elastic or a rubber band or even a balloon and you just grab hold of it and you pull it and you let go and it goes right back to that shape. But eventually, if you keep pulling on it and keep holding it and pulling it to its maximum point and then releasing, eventually it's going to stay stretched out. It is never going to return back to its original stiffness or tightness. You know, it's never going to return back to its original form because you've stretched all those fibers out. Okay, another mechanism that you're going to see happening is hypertrophy. Hypertrophy is an increase in the muscle mass and cardiac wall thickness in response to overwork and strain. It occurs slowly because it takes time for this increased muscle tissue to develop. Initially, the increased contractile power of the muscle fibers leads to an increase in cardiac output and maintenance of tissue perfusion. Over time, though, hypertrophic heart muscle has poor contractility, requires more oxygen to perform work, has poor coronary artery circulation, the tissue becomes more easily ischemic, where it starts dying, and is prone to dysrhythmias. So you have all this dying and dead tissue in the heart, and your heart is not beating effectively, so this leads us into your dysrhythmias on that. Acute decompensated heart failure, or you see it abbreviated ADHF, can be found in your textbook on page 741. Not going to spend a lot of time on this, just need you to kind of know that there is another form of it. ADHF is a sudden onset of signs and symptoms of heart failure. It requires urgent medical condition. What happens is that pulmonary and systemic congestion due to increased left-sided and right-sided filling pressures. So what happens is with universal findings of ADHF is pulmonary and systemic congestion is going to be due to an elevation in left-sided and right-sided filling pressures on that. Excuse me. So this basically is going to, in ADHF, an increase in the pulmonary venous pressure is caused by failure of the left ventricle, and this is going to result in engorgement of the pulmonary vascular system. And as a result, the lungs become less compliant and there is an increased resistance in the small airways. To help compensate, the lymphatic system increases its flow to help maintain a constant volume of the pulmonary extravascular fluid. Sorry for butchering that word. The early stage is clinically associated with a mild increase in the respiratory rate and a decrease in partial pressure of oxygen in arterial blood. This is your PaO2. If you stop and think about respiratory, is it respiratory alkalosis, acidosis? This is kind of where we're getting into with that, with the arterial blood gases. If pulmonary venous pressure continues to increase, the increase in the intravascular pressure causes more fluid to move into the interstitial space than the lymphatics can remove. Interstitial edema occurs during this time. Excuse me. Excuse me. Sorry about that. Tachypnea develops and the patient becomes symptomatic. Examples are they're going to become short of breath. So stop and think about what happens with fluid building up the lungs. What is going to happen? They're going to become short of breath. If pulmonary venous pressure increases further, the alveoli lining cells are disrupted and a fluid-containing red blood cells moves into the alveoli, which is what we call alveolar edema. And as the disruption becomes worse, from further increase in the pulmonary, from the continuing increasing in pressure in the pulmonary venous area, the alveoli and airway are flooded with fluid. This is accompanied by worsening of your ABGs. This is where you're going to start seeing your PaO2 become lower and possibly increase partial pressure. Your CO2 is going to increase. So when you look at your ABGs, what you're seeing is your PaO2 is going to lower, but your CO2 is going to increase. This is getting you into, if you remember, fluid and electrolyte, progressive respiratory acidosis. I told you this is going to when we talked about this with oxygenation, and also when we were talking about fluid electrolytes, it was going to come back and haunt you. Well, here you go. Okay, so with acute decompensated heart failure, you're looking at the clinical manifestations are going to be as pulmonary edema. Remember, this makes it then left-sided heart failure, what it is associated with. So just remember that it's life-threatening because the lungs are filling up with fluid. You have fluid in your lungs, you can't breathe, you die. So, if your heart isn't working, your lungs filling up with fluid, the prognosis is very poor. So this is why a lot of times you see them on diuretic therapy, oxygen, and and several other types of therapies to help pull the fluid out of the lungs, help the heart work better, pump more effectively with that. So just remember, usually if you see anything with pulmonary edema, they're probably looking at left-sided heart failure. Okay, for those of you that kind of are having a hard time kind of seeing in your mind what pulmonary edema is, here's what pulmonary edema would look like. As pulmonary edema progresses, it inhibits oxygen and carbon dioxide exchange at the alveolar capillary interface. If you look at A, that's a normal relationship. B, you've got increased pulmonary capillary hydrostatic pressure, which causes fluid to move from the vascular space into the pulmonary interstitial space. C, you've got the lymphatic flow increases in an attempt to pull fluid back into the vascular or lymphatic space. And D, the failure of the lymphatic flow and worsening of the left heart failure results in the movement of the fluid into the interstitial space of the alveoli. So A is basically the normal relationship, how it's supposed to look, and by the time you get down to D, this is where it's showing you what it will look like with left-sided heart failure. So with pulmonary edema, the clinical manifestations are very distinct. You're going to see the patient's going to be anxious, their skin's going to be pale, cyanotic, they're going to have cool, clammy skin, they're going to have dyspnea. They may even they'll have orthopnea, which is the inability to lay flat because they're short of breath. The anxiousness, I'm going to go back to that in a minute. They're just going to feel like a lot of times they're going to say they feel like they're going to die because they can't breathe. They can't breathe. They kind of panic because they're not getting that breathing. With it, they're going to have tachypnea. They're going to have use of accessory muscles. There's going to be coughing, and this is where you're going to see the frothy blood-tinged sputum, crackles, wheezing, tachycardia, hypotension or hypertension, and then you're going to have abnormal heart sounds at your S3 and S4 with that. Breath sounds with it, like I said, you're going to hear crackles and wheezes throughout the whole lungs. It's not going to be just one specific area. It's going to be throughout all lung bases. The patient's heart rate is going to be rapid, and like I said, you're going to hear abnormal beats at the S3 and S4 sounds. And blood pressure may be elevated or decreased depending on the severity of the type of heart failure. So you do need to know these symptoms of pulmonary edema because it's going to help you when you're dealing with patients that are having heart failure. So with heart failure, the main treatment goals are to treat the underlying cause and contributing factors, maintain cardiac output, reduce symptoms, improve ventricular function, improve quality of life, preserve target organ function, and improve mortality and morbidity. So some of this is you're going to be able to go after modifiable risk factors. Some of them you're going to give them medications to increase the cardiac output. You're going to improve ventricular function. So some of those are going to be more, more drug related. Like I said, we talked about earlier with your ACE block, your ACE medications, Your ACE inhibitors with that, so maybe captopril might be one of the most commonly ones used on that. They may do vasodilators. They may go in or they may use digoxin. Digoxin is very commonly used, especially with people in the nursing home with it. They're going to look at nutritional therapy. You're just going to look overall. As nurses, what you're going to see is you're going to be looking at the treatment. So if you see somebody on digoxin, you know that they have problems with contractility of the heart with it. So you're going to see that. Diet is going to be a big thing because like I said, you want to have them on low sodium diets. You want to have them on heart healthy diets with that. So that's another thing. So be sure you look on page 749. It kind of gives you some ideas in table 34-8 about some low sodium diets that will help you with that. So if you want to, you can refer to page 751 in your chapter, and it talks about patient and caregiving teaching in table 34-10. It talks about dietary therapy, activity therapy, ongoing monitoring, health promotion, rest, and drug therapy. Those are all important things that you're going to do with people in heart failure with that. So as you do your nursing assessment on your person, you're kind of gathering the information as we've talked about. So, if you kind of want to know kind of where you want to be as far as subjective and objective data is when you're doing an assessment with them. If you look on page 750, table 34-9, the top part of it has subjective data, kind of asking the questions what the patient is going to be saying, and then objective data, what you're going to be looking for on that. So that will kind of help you with that, help you with the planning, help you with the nursing interventions with it, and the implementation. Now, one of the biggest things that as you're doing this, I want you to think about a really good nursing diagnosis. So nursing diagnosis, if you think about what heart failure is, it's an impaired cardiac output. So this is impairing maybe gas exchange. So maybe a really good one would be impaired gas exchange related to increased preload and alveolar capillary membrane changes. Something like that. In the book on page 750, it kind of gives you a few nursing diagnoses with that. So just kind of some ideas, because you really need to kind of start thinking along those lines with it, because this is what you're going to be doing in clinicals if you have somebody with heart failure. What is going to be your best nursing diagnosis? And this would be a really good place to look. And this is all for the slide for the PowerPoint presentation on left and right-sided heart failure.